First of all, I would like to start today's class with finishing neurology. We just have a couple of pages left, and then we'll be starting with new subject, psychiatry. So, skeletal muscle relaxant. Previous class, we spoke about different ways that we can relax the muscles. We spoke about the neuromuscular blocking agent, both depolarizing and non-depolarizing. We spoke about their importance since they were utilized pretty commonly in surgery to relax the abdominal muscles for the sake of creating an incision and opening up or closing the incision. The next thing we have to speak about today is a skeletal muscle relaxant, in which this medication can be utilized for muscle spasms. And if you remember, people who have muscle spasm can be those who are suffering from an upper motor neuron symptoms, especially an affection of the cortex or the corticospinal tract. The first one is Baclofan, the Baclofan for your back. Okay. Quite a commonly used drug in multiple sclerosis. You know, people with multiple sclerosis are suffering from this spasticity of their muscles. This spasticity is going to lead to the patient to have this overtoning of his back, which lead him to have really severe pain. He can even sometimes feel an electrical shock going down his back. For that, we give Baclofan, GABA B receptor agonist. Remember, GABA is an inhibitory neurotransmitter in the spinal cord. When it is activated, it's going to lead to muscle relaxation in the neuromuscular junction, which lead to decrease in the muscle spasticity. We utilize it also for dystonia and multiple sclerosis. So, it acts on your back, so it may cause sedation, however. Why? Because it's GABAergic. Remember, many medication work on the GABA receptor, including benzodiazepines, barbiturate, Baclofan, and disease. No, the disease actually don't. So, Cyclobenzaprine. This guy is less commonly used, but it exists. So it acts within the CNS, but mainly in the brainstem, on the pyramids of the brainstem, which contains the corticospinal tract. Okay, so it is used to encounter muscle spasms, also that can be seen in multiple sclerosis. However, they don't like this one. Why? Because it has a really severe side effects. So centrally acting on the brain is structurally related to the TCAs, which is a tricyclic antidepressant. Remember, all tricyclic antidepressant, we'll study them in psychiatry, they do have an anticholinergic adverse effect, meaning an atropine-like effect, meaning that the patient will have fever, mydriasis of their eye, and GI symptoms, so nobody like them. And also they can lead to sedation. The next drug is dantrolene. Everybody loves this drug. So dantrolene, it prevents calcium from, okay, so let's consider this to be a myocyte. This is the sacroplasmatic reticulum, okay, which is like rough endoplasmatic reticulum, but in the skeletal muscle cells, we say that it's a sacroplasmatic reticulum. So the dantrolene will prevent the calcium to be released from the sarcoplasmatic reticulum into the cytoplasm, okay? And it can also lead to an inhibition of something called the renoid receptor. This renoid receptor, well, it's located at multiple places in the body, in the cell, but one of them is on the sarcoplasmatic reticulum. So if you inhibit this guy, it will prevent the calcium from going out. If you prevent the calcium from going out, you will be able to encounter the malignant hyperthermia. What is malignant hyperthermia? Malignant hyperthermia is a condition that we spoke about when we discussed inhaled general anesthetics. And I told you that it can have two causes. The first one was the inhaled anesthetic, and the second cause was the succinylcholine, which is a depolarizing myorelaxant. In the phase 1 of succinylcholine, in the depolarization, can you reverse it, by the way? Just a quick question. Can you reverse succinylcholine action in the first phase of its action? You cannot. You are right. Okay, good. So anyway, so the malignant hyperthermia, this patient will be complaining with a really severe contraction of their muscles. And if you contract your muscle for a really long time, what will happen to the muscle? It will start to, boom, break. releasing myoglobin that can lead to problem in the kidney. Also, the patient have hypothermia. To prevent both of these from occurring, you need to block the calcium channels. Why? Because if you block the calcium channels in the sarcoplasmatic reticulum, and the calcium will not be released into the cytoplasm, can you have contraction without calcium? It's much less likely. Yes, much less likely. So yeah, for that, we use it for malignant hyperthermia, the Dentaline, the blocker of calcium channels. Toxicity of an inhaled anesthetic or succinylcholine is malignant hyperthermia, and it can also be used in case of neuroleptic malignant syndrome, which is a toxicity of antipsychotics. So the antipsychotics, we did not learn this yet. We speak about it again in the psychiatry chapter. Basically, people who take neuroleptic, like haloperidol, they can have toxicity of it when they take so much. So they also can have this muscle symptoms that we'll speak about there. So it acts directly on the muscle. People with neuroleptic malignant syndrome and people with malignant hyperthermia, both of them will have a spasticity of their muscle. The last antispasmodic is Tisanadine. It's an alpha-2 agonist. And does anybody remember which G protein is alpha-2 associated with? Which G protein? GI. So it's an inhibitory. So it acts centrally. It can be utilized for muscle spasticity, multiple sclerosis, amyotrophic lateral sclerosis, and cerebral palsy. I hope you remember, guys, about that multiple sclerosis is a demyelinating disorder of the upper motor neuron that affect oligodendrocyte. ALS, on the other hand, is a pure motor disease that can affect upper motor and lower motor neurons, meaning that the patient will both have upper motor neuron symptoms and lower motor neuron symptoms. Cerebral palsy is a boy that he is born and from birth his cortex is undeveloped, meaning he will be having all of the upper motor neuron symptoms. Opioid analgesics. Oh, okay, guys. So let's say a lady comes to you and tell you, my back is hurting me. What is the first thing to prescribe for her? The weakest. Always start with the weak and go up. So you will start with NSAIDs, okay. But because this is a real life situation, I just prescribe first of all Tylenol. Just paracetamol. It's not that strong. It's super weak. If Tylenol will not work, you will like to step it up. What is more stronger than Tylenol, which is paracetamol? Diclofenac is the third step. The second step is some drug. It's an NSAID called ketorolac, okay? If that does not work, you use diclofenac sodium. If that does not work, you use what? Opioid, right? It's basically the last thing. If nothing works, you go to the opioid, basically. So let's take a look what they write. It acts as an agonist at the opioid receptor, the opioid analgesics. So they can function on the mu receptor. This we call it mu, okay? It's where the beta endorphin is going to work, and the delta, which is where the enkephalin are going to work, and the kappa, which is where the dynorphin are going to work. So what are these things? Endorphin, enkephalin, and dynorphin. They are in your body, in our body, we do produce opioid. We have normal opioid in our body. And you know how you can produce a little bit of opioid in somebody? There is a way to produce opioid in people. How to make people have opioid in them? Well, okay. When somebody is really stressed, you want to calm down this stress, right? Because the stress and the anxiety, it's basically all of this activatory neurotransmitter make you. So you want to calm it down. Yeah, good answer. It's actually a hug. When you hug somebody and people feel this, this connection, they feel more protected. So their brain try to relax them by secreting GABA and opioid. The opioid that the brain secretes include endorphin, enkephalin, and dynorphin, which are going to calm you down and decrease your anxiety. So yeah, more hugs, please. Let's celebrate Corona. So, to modulate synaptic transmission. Okay, so they write, the opioid can close the presynaptic calcium channel. Let's take a look at that. So this is the synapse, basically, right? And there is a calcium channel here, in which where the calcium used to come, the vesicles here used to go and get what? Opened into the synapse, right? So the opioid will close the presynaptic calcium channel and open the postsynaptic potassium channel. That will lead to less synaptic transmission, because postsynaptic potassium channels is basically for the process of repolarization, meaning it will promote the relaxation of the neurotransmitter. If you take a look here, yes, if you take a look here, it's like the opioid can block this guy, and there is one potassium channel here that they can open, which will allow the potassium to go out, even relaxing the neuron even more. The next thing we speak about is, yes, the next thing to speak about is going to be the opioid also can inhibit acetylcholine, norepinephrine, serotonin, glutamate, and substance P. They inhibit everything. What we care really about here is substance P. Why we care so much about substance P? Because substance P is the mediator for pain. Other neurotransmitter that is a mediator for pain is a bradykinin. Okay? So the efficacy. We have full agonist, partial agonist, mixed agonist, and an antagonist, and an inverse agonist. Let's learn about these. A full agonist, that it's a guy that fully work, he's good, it can work at this receptor, stimulate the receptor, and do its function. So a full agonist, it's like morphine, heroin, meperidine. People like, who takes meperidine the most? Doctors. I will tell you why in a second. So in the future, when you decide to become an addict, you will use only this one, not the other ones. Don't be stupid. So methadone is also can be used, and codeine. Each of these has a story. So morphine is clean. It's really rare to find, like in the market, morphine that is super clean, especially within like people who takes morphine. Heroin is a little bit more dirty, and thus it's much more cheaper. So in the US, in the United States, the people who do narcotics, do they take morphine or heroin most of the time? Heroin, exactly. It's less expensive, but it's not clean, meaning that it has much more side effects and it has more risks of messed up things. So meperidine, I told you that the doctors take it. Why? Because remember, when you take the opioid, you will have all of this list of side effects, right? It can lead to your pupil to have pinpoint pupil, meaning your pupils become so small, right? So because of that, as a doctor, if you see somebody with pinpoint pupil, you might know it. You might be like, man, this guy pupil is so small. I think he's in narcotics. I think he's taking opioid or something. That's true. The only medication that does not lead to mydriasis of the eye, to the meiosis of the eye, is meperidine. That's why it's the preferable narcotics for the physicians not to be caught. Methadone is also a long-acting opioid. Codeine, it was utilized previously as a basically anti-cough, antitussive. We say antitussive, which means anti-cough medication. The prodrug is going to be activated by the cytochrome B450, the subtype this guy. Fentanyl is a really, really potent heroin. They consider it to be 10 times more potent than morphine. That means it's super strong. So you would not like to use fentanyl as the first line, actually. So partial agonist, we have a buprenorphine. Buprenorphine is a partial agonist, meaning if you give a partial agonist with nothing with it, just a partial agonist alone, it will work as a full agonist, okay? But if you give the partial agonist together with an agonist, the partial agonist will work as an antagonist. Let me repeat this. I prefer that you write it down. A partial agonist will work like an agonist if it was given alone. A partial agonist will work as an antagonist if you give it with a full agonist. We have some medication that can work both as an agonist and an antagonist. Just a second before I speak about them, I just want to speak about the buprenorphine for a second. So why would I give somebody buprenorphine? Well, you give him buprenorphine, so when he takes it, he feels good. But if he tries to go to the market and buy some heroin to take it, what will happen to him? Withdrawal symptoms, okay? So buprenorphine is not that strong, okay? So if we say that this is the graph, this is morphine, this will be buprenorphine. It's less potent, meaning that it will take the patient, like the patient will have less than its usual dose. So it's a way to get the patient off the morphine. But if the patient decides to take the morphine together with this guy, this will happen. it will become even less. Why? Because the buprenorphine start to work like an antagonist. Mixed agonist-antagonist, we have nalbuphine and bentazocaine and butophenol. They can work as an agonist, as an antagonist. We also can utilize them in withdrawal at smaller numbers. Antagonists, they are used for somebody with a toxicity of opioid. So we have naloxone, naltrexone, and methylnaltrexone. Okay, so we use them for the withdrawal. Guys, I have a question. If somebody was used to take morphine and suddenly stops, he will have really horrible side effects, but is he going to die? Not really. He's not going to die. But if somebody is an alcoholic, really, really severe alcoholic, and he suddenly stops, will he die? Probably. Yes, high chance of death from sudden alcohol withdrawal. You need to taper it down. Alcohol is not the type of medication to just be like, oh yeah, I decided to stop today. No. If you are a long-term alcoholic, you need to taper it down. Otherwise, the patient will die. So the next thing is going to be, the clinical use. Moderate to severe or refractory pain that paracetamol did not work on, which is Tylenol, ketorolac did not work on, naproxen did not work on, diclofenac sodium did not work on, so you need to step it up and give morphine. So it's for moderate or severe refractory pain. It can be used for diarrhea. Why? Because all opioids lead to what? They lead to constipation. So since they lead to the constipation, they were like, okay, so we can give them to treat the diarrhea. Okay, make a few notes. 1. Loperamide cannot pass the blood-brain barrier, meaning that it will not have central effect. It cannot affect your brain. Okay. Also, diphenxylate is the same basically, and so it does not have risk of addiction. Excellent. So that's an important thing to keep in mind. The other thing to keep in mind that loperamide is acting mainly in the intestine, which lead to the inhibition of the peristalsis. So it's contraindicated sometimes, especially in patients who have, for example, an infectious form of diarrhea. Okay? If you have an infectious form of diarrhea and there is bacteria in your intestine, would you like to just stop the peristalsis so the bacteria can stay in your intestine and they proliferate more often and kill you? Absolutely not. So you would like not to do that. That's why in people who have some forms like Campylobacter jejuni, we never give loperamide. Why? But he has gastroenteritis. Let it just clear out. Just give him a fluid and that's it. In a non-infectious diarrhea, yes, you can give it. Acute pulmonary edema can be utilized opioid for it because it can lead to vasoconstrictions. And maintenance program for opioid use disorder. Okay, so somebody who takes opioid and he comes to you, he's like, doctor, can you help me to stop? Like, yeah, sure. So guys, who is more addictive? Short-acting opioid or long-acting opioid? The short-acting one, absolutely, because they act like this, right? Well, the long-acting acts like this. So the short-acting have much more euphoria than the long-acting. So methadone is a long-acting opioid. It can also prolong the QT interval. Please make a note about this. It can prolong the QT interval, which can promote to torsade de bois. Okay? A buprenorphine with naloxone can be given. This is an antagonist and this is a partial agonist, meaning if the patient tries to go behind your back and take the opioid, he will feel bad. Why? Because the buprenorphine will start acting as an antagonist. Okay? And we have also naloxone, which work as an antagonist itself. We have something called neonatal abstinence syndrome. What is this neonatal abstinence syndrome? It's a baby that his mother used to take the opioid. Okay? Absolutely. So his mommy is an addict, and she was an addict for a long period of time, and she used to take this narcotics when she was pregnant with the baby. I know, really messed up. Speak more about it in reproductive, but anyway. So she kept taking the medication, okay? So that will lead to something known as neonatal abstinence syndrome. Why? Well, basically, in the neonatal abstinence syndrome, basically the baby is now an addict, right? So what is the story? A baby is born, he's born fine, I've got a score is good, everything is fine with him. 10 hours after birth, he starts screaming, crying. You cannot make him calm. He does not want to eat, he does not want to drink. The baby is suffering from really profuse diarrhea at the same time, and you cannot understand why. Mommy has a previous history of substance abuse, neonatal abstinence syndrome. For that, you give a methadone, which is a long-acting opioid, but even before that, give him a shot of morphine just to calm him down. And then keep him on the methadone, and then taper it down until he can stop it and continue his normal life. Okay, adverse effect of opioid, nausea, vomiting, and pruritus. Why? Remember, it is like vancomycin, the opioid. It can directly bind to the mast cells, which can release the histamine, right? So opioid use disorder and respiratory depression, which is the cause of death in an overdose, the respiratory depression. And also it can lead to constipation, that's why we have loperamide, and sphincter of odyspasm, which can promote to pancreatitis. Meiosis, except meperidine, will lead, meiosis with all medication except meperidine, it leads to mydriasis, so you will not be caught. And additive CNS depression with other drugs. So if don't ever use benzodiazepines together with an opioid, or benzodiazepines and barbiturate with opioid. That's just the perfect killer. Or decide to, actually a lot of people die, from what? They take like this morphine and they drink alcohol at the same time. So when they do both of them together, done. CNS depression from both of them, respiratory depression for both of them, goodbye. Tolerance do not develop to meiosis and constipation, which means if you take opioid, you will have this euphoria, you will be really happy. If you take it again, you will have euphoria, you will be so happy. If you take it like after 100 times, will it have the same effect, or you will just become tolerated? You will just take it to prevent feeling the pain, basically. Become tolerated. People start to take it just because they are an addict and they just feel an internal emotional pain that they want to decrease. So tolerance do not develop to the meiosis and constipation, meaning that for the pain, yes, there will be tolerance. You will stop feeling the happiness from the opioid. However, you will still get the meiosis and the constipation. Treat toxicity with naloxone and prevent the relapse with naltrexone. Naloxone is a quick-acting medication. Naltrexone is a long-acting medication, okay? Tramadol. Very weak opioid agonist. It's very weak. It's really common, actually, drug of abuse. So very weak opioid agonist. Also, actually, the story I told you, like paracetamol, you move up from paracetamol to ketorolac, you move up into naproxen / diclofenac sodium, and then you move up to a weak opioid like tramadol, and then you move up to a full opioid such as morphine. So also inhibit the reuptake of norepinephrine and serotonin. It's for chronic pain, but because it does this, it makes people happy. So it can lead to also mild euphoria. That's what they do. So similar to opioid, the adverse effect, which is the constipation, the meiosis, all of this stuff, but it decreases seizure threshold, meaning it can promote to seizure. Also, people who take a tramadol and together with it decide to take like Jameson weed forgot its name. Just a moment. St. John. Oh yeah, St. John weed, which is a form of a serotinogogue type of substance to make people happy. These are, when you take these together, you can get serotonin syndrome. Speak about serotonin syndrome in psychiatry. Tramadol is really quite common in the market. It's people with cancer, for example, use it a lot, but people also do abuse it a lot. Mixed agonist and an antagonist of an opioid, we have benzocaine. As I said, they can be used in cases of pain, like the long-term pain, but at the same time, they don't like to have the, how do you call it? the euphoria. Not well, everybody like the euphoria, but basically you don't want to get the patient used to it. Okay. So the mechanism of benzocaine, it's a kappa opioid receptor agonist and the mu receptor and a weak working on the mu receptor. Okay. So because of that, the mu receptor actually, there was a study that said the mu receptor is the receptor of the addiction. So yeah, it's an antagonist at the mu receptor or a partial agonist. So if you try to take opioid with it, another morphine, you will feel bad. Okay, analgesia for moderate to severe pain can cause opioid withdrawal symptoms if the patient is also taking a full agonist. Why? Because a full agonist together with a partial agonist will work as an antagonist, right? I mean, the partial agonist will work as an antagonist. And butorphanol, it's at the kappa opioid receptor agonist and the mu receptor partial agonist. Again, for severe pain, migraine, or labor itself, which is delivery, causes less respiratory depression than full opioid agonist. Use with a full opioid agonist can precipitate withdrawal as well. Why? Because it's a partial agonist. If you use it with a full agonist, it's going to lead to function as an antagonist. It's not easily reversible by naloxone. Okay, the next drug is quite common. We always see it seen, especially in elderly population. So it's capsaicin, which is naturally found in hot pepper. You know, when you take a pepper, cut it, put it in your skin, it will burn, right? Yes. So also they take it out from there and they like took this substance from it. And when they started to put it on the skin, they realized something. It burns, but after it burned, the pain goes away from that area, okay? So excessive stimulation and desensitization of the nociceptive fibers. So initially when you put the medication, you apply it topically on your skin, you will feel like it burns, but then it will go away and the pain will go away. It decreases substance P, which is the mediator of pain. So it can be utilized in musculoskeletal and neuropathic pain. Glaucoma therapy. The treatment of glaucoma. Well, our main job is to decrease the intraocular pressure either by decreasing the aqueous humorous synthesis or the aqueous humorous drainage, right? You need to decrease it. So beta blockers, all of these ends with olol. They decrease the synthesis of the aqueous humorous, which is secreted from something known as the ciliary body. Let me show you the ciliary body. Okay, so this is the ciliary body that actually make the CSF. So that will be inhibited, okay? So the next thing here, yeah, no pupillary or vision changes, it just help to secrete less the aqueous humorous. Alpha agonist, we have an alpha 1 agonist and alpha 2 agonist, they function differently. The alpha 1 agonist will decrease the aqueous humorous production via vasoconstriction, okay? Good. And the alpha 2 agonist is a GI mediated, so also it can lead to disinhibition directly, not by vasoconstriction, but in the same time, the alpha 2 can open something known as the Uversecular Pathway. I'm not sure where to find this, but Uversecular Pathway is a minor pathway. Yes, is a minor pathway for the aqueous humorous release from the anterior chamber. So this is the ciliary body, which makes the aqueous humorous. Then it goes to the posterior chamber, then to the anterior chamber, and it can go to one of two ways. Either it can go to the uversecular pathway or the trabecular outflow. Trabecular outflow tend to be the more dominant type of drainage. Okay, so the next thing, let's see here. So they write increase outflow of aqueous humor via the uversecular pathway. Mydriasis can be mediated by alpha 1. Do not use it in a closed angle glaucoma, blurry vision, ocular hyperemia, foreign body sensation. The patient can feel inside of their eye, ocular allergic reaction, and even in the eye it can become itchy because of the vasoconstriction. Diuretics. So diuretics can be utilized such as acetazolamide. Remember, acetazolamide, we like to use it for also like hydrocephalus. So it decreases the aqueous humorous synthesis via the inhibition of carbonic anhydrase. Number two, that is located at the ciliary body as well, meaning that is going to decrease the amount of synthesis of aqueous humorous. It does not have any pupillary or vision changes, however. It solely acts at the ciliary body. Prostaglandins, ladies love it. So we have the bimtoprost and the lanatoprost. Basically, they are a prostaglandins F2 alpha. And this prostaglandins analog, when you give them to the patient, they are going to increase the outflow of the aqueous humorous through the Uversecular Pathway, the minor pathway basically, okay? However, what you should know about this, that the prostaglandins have a side effect that ladies love. They can lead to two side effects. They can darken your iris, but that's not what they like it for. Makes it more brown. They like it because it makes your eyelashes grow much longer, okay? So if it's given topically, it can make your eyelashes become much more stronger and longer. So cholinomimetics. Cholinomimetics, they are, there is the direct ones and there is the indirect ones. Basically, both of them will increase the action of acetylcholine. Bilocarbine, carbachol, physiostigmine, or ecothiopate. So they will increase the outflow of aqueous humorous. How? Because it's a parasympathetic analog. So what will happen to your pupil? Parasympathetic. Meiosis or mydriasis? Meiosis. So the pupil becomes smaller, right? When the pupils become smaller, just take a look at this. This is the iris, right? So the iris, it will go to this side, to the right, basically. So what is going to happen to the trabecular outflow and the uvascular outflow? When this piece goes to this side, it's going to open up, right? It's going to open up more. So it's opening up more because the meiosis has occurred. The iris went to the, like, centrally. So this area will be opened, which will allow the fluid to release into the canal of Schlemm and the trabecular meshwork and eventually the abscleral vein and the uversecular pathway. So they write, an increased outflow of the aqueous humorous via the contraction of the ciliary muscle and the opening of the trabecular meshwork. Used bilocarbine in an acute angle closure glaucoma is very effective at opening the meshwork into the canal of Schlemm, as we said. So it can lead to meiosis, obviously, that's how it reads. Contraction of the pupillary sphincter muscle and cyclospasm, which means cyclospasm, that means that your lens is not going to function normally. Contraction of the ciliary muscles, that means that how do you say this correctly? When you take a look at a sign that is far away from you, it will be blurry, okay? So your accommodation will be bad. The accommodation of your eye will be bad. Okay, guys, so this is it for CNS. Now we'll take a little break, come back, and start hitting psychiatry, hopefully finish with the ego defenses today. So see you guys in 10 minutes. Okay. So, psychiatry, ego defenses. Oh, sorry, before ego defenses, there is the topic of conditioning. So what is conditioning? It's just like, look, in psychiatry, there is not much to explain. You should just know the stories. There is plenty of stories that I'm going to tell you, and you just need to listen to the story and associate it with a real life event or with a patient. So, what is conditioning? For example, I have a dog. No, actually, I had a cat. And this cat, it used to keep going on the table for food, and I did not want her to do that. Regardless, every time I have food on the table, it used to jump and go on the table. So I thought about it, and somebody told me, well, just spray her with water every time she goes on the table. First time, I spray her with the water. She got annoyed, she jumped down. Next time she went up on the table, I sprayed her again. She went down. Again, she went down. Again, she went down. She stopped wanting to go on the table. Why? Because if she goes on the table, she knows she will get sprayed with water. These things can be also done with the human beings. Okay? If you keep refusing somebody, he will eventually give up. He will be like, if I try again, I will get rejected. So I should not. Also, there is the other story about the bell and the salivation. So basically, there was a guy called Pavlov. And this Pavlov guy, he bring a dog. And he put the dog And each time there was this is a dog. I don't know how this is a dog, but this is a dog. He bring him food, and every time before giving him the food, and sometimes he had a bell, okay? And yeah, basically he rang the bell every time the dog was supposed to eat the food. So each time the bell rang, the dog had food. After some times he did not give him food, he just rang the bell. What happened to the dog? His saliva went down. Okay? Why his saliva went down? This is classical conditioning. Classical conditioning is learning in which a natural response, salivation, is elicited by a conditioned or learned stimulus, which is the bell, that previously was presented in conjunction with an unconditioned stimuli, which is the food. So the unconditioned stimulus in this case is the food, right? This is something you cannot, well, it's not the conditioned cause. So again, dog. So D for dog. Dog, food, bell, and that's it. So when you gave them together, the bell was the conditioned, the stimulus, sorry, and the food was the unconditioned stimulus that made the dog to salivate, right? So now if the food is absent but the bell is present, the dog will still salivate. That's a classical conditioning. Usually elicit involuntary responsive. Pavlov classical experiment with dogs ringing the bell provoked salivation. This must be learned by you because you need to understand some action that occur around you. For example, let's imagine that you are a head of a hospital and your physician keeps coming late to work, right? Each time a physician is late, you are going to, I don't know, well, make him clean the floors or something. Just give him some form of punishment. He will stop doing it. Or actually, this is operative conditioning. Let's say that each time the physician watch his hand, he gets a candy, okay? So after some times, the physician will be like, oh, I should wash my hand to have the candy. Then remove the candy. The physician will keep washing his hand, even without the candy. That's a classical conditioning. Operant conditioning is a little bit different, is learning in which a practical action is elicited because it produces a punishment or a reward. So if it produces a punishment, you want to do it less. If it reduces a reward, you want to do it more. Usually elicit voluntary responses. So here it's involuntary responses, here is voluntary responses. Okay, I made a little mistake actually. Salivation, urination, defecation, all of these stuff are involuntary. But you, for example, taking out the trash, washing your hand, stuff like that. So that was a mistake example. So washing your hand, all of these stuff, will be voluntary conditioning, which is operant conditioning. Learning in which a particular action is illicit because it produces a punishment or a reward. Voluntary. So we have reinforcement and punishment. Okay, so what is this? We have reinforcement, both positive and negative. We have punishment, both positive and negative, and we have extension. So reinforcement. Target behavior is followed by a desired reward. For example, each time you are going to solve one block of U-word, I'm going to give you candy. So you are like, oh, nice. So every time I finish a block of U-word, I'm going to get candy. So I will be doing more U-word, right? So that what I have done for you is a positive reinforcement, okay? On the other hand, I tell you, this is positive reinforcement. You did something and I gave you a reward for it, right? Okay, what about negative reinforcement? Negative reinforcement, let's say, each time you do a block of U-word, I'm going to make you not to attend the class, for example, okay? So that's negative reinforcement. Okay, so negative reinforcement is removing something that the patient feels bad about it if he does the good thing that you wanted him to do. That's negative reinforcement. So, do more things, get more candy. Positive reinforcement. Do more things, get less punishment. Get less pain, basically. Negative reinforcement. Okay. Punishment. Punishment is different from the reinforcement, totally different. Repeated application of aversive stimuli, which is positive punishment, or removal of desired reward. It's negative punishment. So how to differentiate between them? Well, you tell the patient you must decrease your behavior. In the reinforcement, in both of them, positive and negative, we were increasing the doing of you word equation. We were increasing the tasks, absolutely. But in case of punishment, we want him to decrease his action. For example, a smoker, okay? Positive punishment is anytime you caught the patient smoke, you will spank him. You will kick him, okay? Just physically insult him. That's positive punishment. Or anytime you see the patient smoking, you are like, okay, no cookies for you. You are grounded, right? That's negative punishment. Because you are just removing something that he wants. That's negative punishment. Okay, so in general, reinforcement to increase the behavior, for example, going more often to the gym, and like punishment is to decrease the behavior. For example, wife and the man. The wife tells the man, each time you go to the gym, I'm going to make you cake. So what type of conditioning is it? Each time you go to the gym, I'm going to make you a cake. It's reinforcement, absolutely, because he's doing it more often, and she makes him a cake, which is something he wants. So, is she adding or removing a stimulus? She's adding a stimulus, so it's positive reinforcement. Okay, a man is sitting with his family on the dinner, and he tells his child, look, if you fail this year exam, I'm going to kick your ass. What do you think? It's punishment, but it's not negative, it's positive. You added a stimuli. The stimulus was kicking his ass. Okay. But if I say, if you fail this year exam, I'm going to take your Xbox away. Xbox is a device for gaming. Negative punishment, absolutely. You are decreasing his behavior, and negative because you are removing a stimulus. Okay, let's try one more. This is tricky. Let's say somebody... I'm just trying to put one and putting an example according to it. Okay, so a woman tell her man, if you earn more money, I am not going to ask you to take out the trash. Reinforcement, correct? Negative, absolutely. Why reinforcement? Earning more money. Reinforcement. Not taking out the trash, removing of the stimulus. So negative reinforcement, perfect. Okay, good. So this is something that you need to be careful about, guys, which is transference and counter-transference. I see it happens a lot. You need to care about your patient. You need to do the best for your patient. But you need to keep in mind that this patient is a patient. It's not a family member, okay? Always keep that in mind. Why? Because if you consider the patient to be a family member, you might give him more harm than good. You might not give him a treatment or an intervention because it hurts. But he needs it. So that's why, be careful of that. A patient is a patient, not a family member. Transference. Patient projects feeling about formative or other important person into a physician. Psychiatrist is seen as a parent. So for example, the patient is like, that doctor feels like he's my father. He's so good. He's so attentive on me. He cares about me so much. In this case, the patient is thinking about you to be like his father. Okay, that's a transference. This is fine. Don't worry about it. But The problem is with the countertransference, okay? Countertransference is when the physician project feeling about formative or other important person into his life. Patient reminds the physician of younger siblings. So the physician will be like, oh yeah, that physician in room number 5, he reminds me of my youngest child. Oops. Okay, that means you are going to have emotion for that children, which means you can do stupid stuff that you should not do sometimes by preventing him from getting really invasive treatments, right? So, yeah. Okay, the next thing is ego defenses. Ego defenses is something that you need to be super careful about. There is 2 types of ego defenses. They are thoughts or behavior that are voluntary or even involuntary, used to resolve a conflict and to prevent an undesirable feeling like depression or anxiety. Let me tell you a little bit about this. Ego defenses, we have the immature types and the mature types. Immature types is used by people who are idiots, okay? The mature types is used by people who know what's up, like who understand these ego defenses. I mean, not always understand, but at least they understand themselves, and it's stupid to use the immature defenses, okay? For example, the immature defenses is acting out. Acting out, it's goes something like this: subconsciously coping with a stressor or an emotional conflict using an action rather than reflection or feelings. For example, let's say that yes, I come to the class and nobody is here. Okay, I come to the class and nobody is here. So I will feel bad about it, right? So I will decide to cancel 3 classes. That's acting out. Is it mature? No, it's stupid. It's an immature ego defense. Okay? But the patient will be doing it just to look like a badass, you know? A patient skips therapy appointment after deep discomfort from dealing with his past. For example, you tell the patient each time he comes to you, the patient came to you and you tell him, man, your smoking is killing you. You need to stop smoking. And he's like, okay. Never comes back. Acting out. Okay? Denial. Avoiding the awareness of some painful reality. This is actually quite common. Even in accepting really bad news, patients tend to have a lot of denial. Come to somebody, tell him your close relative has died. What will be the initial most response? Tell him, come to the patient, tell him your father died. He'll be like, no, it's not true. No way. Yeah, denial. Yeah, exactly. So remember, for any acceptance of bad news, you start with denial. You are like, no way. Yeah, and then you start to become angry. Anger is like, no way. You should have done something. No, no, no. So anger is next step. Third step is bargaining, which means like, man, doctor, is there nothing else we can do? Maybe we can give him electrical shock or something to put him back in life. So he starts to do this bargaining with you, you know? And this is the third step, bargaining. The fourth step is depression. He just sit and become depressed and like, oh yeah. And the fifth step, he just acceptance. He accept the bad news and that's it. So the first one is denial. He's avoiding the awareness of stimuli. For example, a patient with cancer plans a full-time job work schedule despite being warned of significant fatigue during the chemotherapy. The patient knows that he's going to die. The patient knows that the chemotherapy sucks, but he will deny that because he has basically an immature way of thinking that everything will be good. Displacement is quite common. I will tell you the story. You will attach us to something else. Okay, guys, I go to work. My boss screams at me. I come back home. I scream at my wife. My wife screams at my child. My child screams at the cat. What is happening? Displacement of negative emotion. And why the boss screamed at me? Well, his wife screamed at him. Okay. Why his wife screamed at him? Because my wife screamed at her. Wow. Okay. It's not the same as a projection. Projection is different. You will see. Redirection of emotion or impulses to a neutral person or object. versus projection. Why? For example, this displacement, I take the emotion from my boss and I put it on my wife. Projection, I hate my boss, right? So I give him the silent treatment. Okay? He calls me and I'm not going to respond. That's silent treatment. Okay? Or for example, I subtly ruin his day without him knowing. For example, like I hate him. So I start to talk shit about him in front of other employees. That's projection. So, but displacement is just like I take the negative emotion from him and I take it to another neutral person that is not harmful for me. After being reprimanded by the principal, a frustrated teacher returned home and criticizes his wife cooking instead of confronting the principal directly. Yep. Just if somebody do displacement on you or scream at you, stand up for yourself, because otherwise you are going to move it somewhere. So if somebody do it to you, tell him, calm down and let's speak about it. Why are you screaming? I can hear you. Or if somebody criticizes you, tell him, yeah, I know, I understand. I'm not as good as you. You are amazing. When you say such thing, he totally understands that you are fucking with him. But the way you say it, it makes him think. Actually, it makes him feel stuck, because he cannot continue to criticize you because you are saying good things about him, so he gets confused. His brain cannot function anymore. And at the same time, you totally realize what you have done with him. So you will be happy and he will be super confused for the next 4 or 5 days. Okay, disassociation. Disassociation, it's quite common and really, really sad event. Temporary or a drastic change in personality, memory, consciousness, or motor behavior to avoid emotional stress. Patient has an incomplete or no memory of the traumatic event. Basically, it's really common in ladies who undergo sexual abuse. They will forget the abuser. They will forget what happened exactly. They will forget everything, okay? Then after that, for example, you bring that abuser and you put it in the police department. When you bring the lady and ask her, is that the person who abused you? What she will say? Absolutely nothing. She will just sit down and do nothing. She will become numb, detached, and disassociated from what is ever happening around her. A survivor of sexual abuse sees the abuser and suddenly becomes numb and detached because of that traumatic event. Continuation of the ego defenses, we have fixation. Yep. Fixation is to be stuck in a previous milestone of life. You remember, when we were child, we used to lactate. After we lactated, we become a little bit older, so 3-4 years old, it's not logical to go and drink milk from mom. So we started sucking our thumb to feel more relief and decrease the anxiety. When we get older a little bit, it's not acceptable to suck our thumb anymore, so we start smoking, which is some object that we constantly put in our mouth. Actually, before that, we take the pencils or the pen, we start biting on them, right? But when you get older, you cannot just keep like sucking and biting on a pencil, so you bring a cigarette. Fixation is partially remaining at a more childish level of development versus regression, in which you already become mature and then suddenly you become immature, okay? So a college student studying for a stressful began to suck his thumb. So yeah, that's a previous milestone, but he's fixating on it. Why? Because of the stressful event. Idealization is expressing extremely positive thoughts of self and others while ignoring the negative one. So, for example, you went into a trip into Mexico, and during that trip you got watery diarrhea, you had severe vomiting, and you had a really, really bad event. It was really bad, okay? But when they ask you about it, years later, you are like, it was an amazing trip. I had to go with my family. We sat on the beach and we come back. You idealized that, okay? It can be a person, it can be a place. So a patient boasts about his physician and his accomplishment while ignoring his flaws. Identification, largely unconscious assumption of the characteristic qualities or the traits of another person or the groups. Oh, that's just horrible. This is the um, pretty interesting. So when you take a look at your, for example, let's say that I'm a doctor. I see my attendee, and I know that my attendee is amazing. You know, he's like the boss there, and I wanna like be with him. I wanna be boss like him. And what should I do? I start acting like him. If he walks in one way, I start walking like him. If he wears his lab coat in one way, I start wearing it like him, right? Because I am so wanting to be like that guy, okay? So, by the way, identification can also play another role in which it includes something like stereotypes, which is actually can be bad. So it can be this one that I told you, and also it can be the stereotypes. So keep that in mind. So they write, a resident start putting his stethoscope in his pocket like his favorite attendant do it, instead of wearing it around his neck like he used to do. Okay? Intellectualization. Oh yeah, using facts and logic to emotionally distance oneself from the stressful situation. What do I mean by that? Patient has cancer. He start asking you what is the pathophysiology of the disease, what is the risk factor, how it occurred, and stuff like that. He's not asking about the treatment. He's just trying to get more info from you. Is that useful for him? In reality, no, it's not. But why he's doing it? Why he's doing it? It gives him comfort. It makes him more comfortable. Okay, gives him comfort. So that's intellectualization. Isolation, do not mistaking it to like schizoid, which is a little bit later. So they write isolation, separating feeling from ideas or event. So please, guys, do not mistaking isolation with disassociation. Disassociation, the patient forgets everything. Okay, disassociation, she just forget. She has no idea of the event. She's numb. She's disassociated from the situation she is right now. Isolation, however, a patient who have witnessed murder in front of him. He tells you, yes, well, the man just grabbed his knife and he started sticking it into the victim slowly, and he described it with no emotion, you know? Why? Because he's doing isolation to comfort himself. So it's separating feeling from ideas or event. Passive aggression. Oh yeah, my favorite. Okay, passive aggression is demonstrating hostile feeling in a non-conferential manner. It looks a little bit like projection, by the way. Showing indirect opposition. For example, my manager, my boss at work sucks. I hate him so much. I cannot tell him that I hate him so much. So I start ruining his work by coming late, by like, for example, sabotaging his work, by taking his document, put it in the garbage. But I will not directly tell him that I hate you. I just will do it passively, passive aggression. So for example, also sometimes it's really common in people with borderline personality disorder. These ladies, sorry to say ladies, but it's just more common in ladies. The man do something for her, and she's like, you don't love me anymore. And he's like, well, I did not say that. I do. She's like, okay. She will try to always find a conflict. Regardless of how good you try to make it, she will find a conflict. So what conflict can be? For example, she can give you the silent treatment, not speak with you. Or you have no idea what have you done. Or for example, you did not remember about the anniversary, so she give you silent treatment. Or she makes hole in your jacket. It doesn't matter. It's passive aggression. She's not confronting you and telling you about the problem. A projection is something like this. For example, I do something bad. I tell my wife, you did something bad. For example, I cheat on my wife. I tell my wife, you are cheating on me. She's like, what? She did not. I did. So I'm projecting my own thoughts and my own action on her. That's a projection. So, for example, a man who cheats on his wife accuses his wife of being unfaithful. Rationalization is asserting a plausible explanation for an event that actually occurred for other reasons, usually to avoid self-blame. Oh, these are just assholes. Okay, so rationalization. What's up of this thing? It could be comforting for the patient, for example, like if I get kicked out from my job, be like, I did not care about this job anyway. It doesn't matter. I'm more important than that. Yeah, that's rationalization to make myself more comfortable. If I got expelled from the university, I'll be like, I did not care about that university. It was a bad university anyhow. Okay? If I failed USMLE, I'll be like, actually, the USMLE scoring system sucks, which it does. But yeah, I will say it only because I failed the exam. Reaction formation. Reaction formation is replacing a worded of idea or feeling with an emphasis on its opposite versus sublimation. What does that even mean? So they write, let's say, like a stepmother and a child. She hates that boy. She hates his gut. She treats him like an angel. Why? That's reaction formation. You really hate the person, you do exactly the opposite to him. You are like, what the F? But it's true. That's what happens. Basically, they start to do the exact opposite of the emotion they have for that person. For example, one more example, let's try to do. You hate your group mate, so you started bringing him candy to class. That's reaction formation. Regression. Regression is different from fixation. Regression, involuntary withholding of ideas or feeling from consciousness. Oh, sorry, that's wrong. Okay. So I was reading regression. I wanted to speak about regression. Involuntary, turning back the maturational clock to a behavior previously demonstrated under stress. For example, a baby who was like not a baby, a child, maybe he's 6 years old. He already know how to use the toilet, right? Then his brother was diagnosed with cancer. It's a really question, I saw it. So his brother was diagnosed with cancer. Now he started with his bed again. That's regression. He went to a previous milestones. Do not mistake it with fixation. Fixation, it was never solved from that guy. He was always sucking his thumb. It did never go away. He always do it. So repression is involuntary withholding of an idea or feeling from conscious awareness. So this is bad. Suppression is good. They look the same. So the bad things about repression, that it's involuntary. The good thing about suppression, that it's voluntary, it's intentional. So you hold the ideas and the feeling not to go out. For example, a 20-year-old not remember going through the counseling during his parent divorce 10 years ago. He truly does not remember. So that's repression, just to comfort himself. While in case of suppression, he does not remember because he realized that there is no time for that. Splitting. Oh, bipolar, love it. So, sorry, not bipolar, borderline. Borderline personality disorder, love it. Believing that people are either all good or all bad. For example, they are like, oh, I went to the hospital, all of the doctors are perfect, but all of the nurses sucks. They are really bad. That's splitting. Like, you take one group of people and you make them like eutybiased. You make them just perfect. Another group of people, you say they are totally bad. Mature defenses include sublimation, which is replacing an unacceptable wish with a course of action that is similar to the wish, but socially acceptable. For example, let's say that I like to hurt people. Instead of hurting people directly, I will go and do street fighting, and or boxing. I will get a medal. People will be like, yeah, you are amazing. But in reality, I just wanted to do it because I like hitting people. It's a smart, so it's considered as a mature defense. Altruism, it's this mafia boss who give a large donation. For example, I feel I'm a really bad person. I do a lot of bad things in my life, so I want to give back to the community. So I'm becoming more generous. I give like $1 million for the poor, regardless of the fact that I gained all of my wealth from killing people. So that's generosity. That's altruism. I forgot his name. There was a guy who used to be a mob boss, a mafia boss in South America. Pablo de Escobar. Pablo de Escobar. He used to have a lot of money that he gained from what? From narcotics, from cocaine. But this man used to build schools, used to build churches, houses, places for people to stay. What the hell is wrong with him? Well, it's altruism. It makes him feel good about himself. Suppression, intentionally suppressing an idea or feeling from conscious awareness. This is important, it's temporary. For example, look, you had some issues. For example, you break up with your boyfriend or girlfriend, and it's a bad emotion. You decide that my USMLE Step 1 exam is going to be in 2 months. I don't have time to deal with it, so for now I'm going to suppress this emotion and not think about it until 2 months from now. 2 months from now, after I do my exam, I can release this emotion. But for now, I don't care about this emotion, I'm just going to focus on my studying. That's suppression. A humor, it's making fun out of really bad stuff. For example, a nervous medical student jokes about the board. Yep, that's humor. Lightheartedly expressing uncomfortable feeling to shift the intentional focus away from distress, which is basically like, for example, like in cases of wars, person make fun of the wars, making fun of the events of the war and stuff like that, just to comfort himself, you know. The next thing I'm going to speak about is grief. So grief, and after the grief I might stop, but I want something from you guys. See this page, which is child development. Please do print it, and I'm going to share a picture with you that is also helpful for it. So basically the grief is going to go something like this. Grief is normal, guys. When we lose somebody, it's totally all right to lose it, to have this sadness. What I want you to know, however, that sadness in case of a grief should be like this, meaning that it comes and go. Even when you break up with somebody, the sadness should be coming and going. But now I'm making it in a pathological fashion. Why? Because it's increasing. So the griefs and the ways of sadness should be like this. So yeah, it comes in bouts in which you become sad, happy, sad, happy, sad, happy. But overall, after sometimes it should just flatline, in which you will become less sad. So grief, natural feeling that occurs in response to the death of a loved one. Symptoms are a trajectory vary for each individual. They are specific for each loss and do not follow a fixed serious stages. In addition to guilt, the patient feels guilty. For example, the wife feels guilty about mistreating her husband sometimes, you know? Sadness, yearning, like, oh my God, my husband, poor man, I lost him. And patient may experience somatic symptoms. For example, they can literally feeling like pains in their arms and their legs. They can feel actual symptoms. Or they can feel like their heart is has stopped, or their heart is paining them. Hallucination of the deceased. People think this is pathological. I mean, they can literally see the person who died. Is this pathological to see the person who died on the street? Looking at them, winking at them. It's not pathological, guys. No, it's not pathological. It's totally normal in the first 6 months after the person dies. This is a psychological hit, meaning that even if you see this stuff, it's okay. It's your brain way of adapting to it. Hallucination of a deceased and or a transient episode of wishing that they were dead with him. However, you need to be careful of these words. With or instead of their loved ones. And they are like, oh, why God you took him? Why you did not take me instead? Okay, so you are wishing that you've been dead instead of your husband. Will you kill yourself now? No, of course not. Okay, so you are not suicidal. That's the important question. You need to make sure that this patient in front of you is not planning to commit suicide to join the loved ones. Yes, he would love to be dead so he can join the loved ones, but he would not like to kill himself to join the loved ones. Okay? Typical acute grief is time limited, which is about 6 months. Okay? And is not a disorder. In children, it can be up to 1 year. Complicated grief, which is persistent complex bereavement disorder, it lasts forever. Can be diagnosed if thoughts are persistent and prolonged. Yeah, I wish I die and enjoy my husband. When did he die? 16 years ago. So that's too much. Significantly impaired function. What do you do in your life? I became homeless because I could not pay for the bills because after my husband dies, I could not work. I felt like I'm just gone. And do not meet other criteria for other disorders like MDD, major depressive disorder. It does not meet MDD. MDD, you should have other stuff. We will learn about it later. So, for this one, the milestones, there is plenty of them. And I will send you a picture after the class explaining what exactly you have to know and what is complete bullshit. What I want you to know exactly from it is the motor, all of them are important, of course. But if I say the word regression, it means that you have gained something and you went back at a previous stage. Infant is until 12 months. Toddler is until 36 months, which is like 1 year to 3 years. Preschooler from 3 years to 5 years. Just know in general what they are. Know the primitive reflexes and what they are. They happen because of demyelination of the corticospinal tract. You need to know that the child... until 6 months, or actually 4 months, he cannot roll over, meaning that if his mother tells you that he rolled over and got a subdural hematoma, she's lying. Know when the pincer grasp happens by 10 months. Know when the social smile starts, stranger anxiety starts, and when it disappears as well, okay? Know when the child is telling you it's mine, which is a toddler. He likes to own stuff. And please know about the thing that when the patient starts recognizes his own name, okay? And when he starts to say mama, dada, that's by 10 months, and at 12 months he should use at least one more word, which is duda or something like that, like baba could be as well. Okay. So the toddler, however, have different stuff. So they have this, basically again, the motor stuff, social stuff, and verbal stuff. When the person is a toddler, he can speak like 50 to 200 words, and by 3 years old, he can use 300. By 3 to 5 years old, he can use 1,000. He's already fluent. So if it lasts until this period and he cannot speak good, take him to a doctor and check up what's the problem. It could be autism, okay? Actually, you can diagnose autism as early as 2 years old. Okay, guys, and you need to know all of the motor stuff and how they go one by one. They are a lot. There is no, it's not a good idea to explain all of them because you will forget them the moment I finish. But I will send you a baiting that you just need to follow. And according to what is written in it, it's enough for the USMLE. So if you find this to be too tight for you, just know the graph that I will send for you. Other than that, that's it for today, guys, and I will